This conference will now be recorded.
Good morning all. Today we are going to discuss about COPD. COPD. It is defined as chronic obstructive pulmonary disease. It is a disease characterized by airflow limitation, which is not fully reversible. It includes two components, emphysema or chronic bronchitis. Chronic bronchitis. It is defined as chronic inflammation of lower respiratory tract characterized by excessive mucus secretion, cough, dyspnea associated with recurrent infections of lower respiratory tract. Emphysema is a complex lung disease characterized by damage to gas exchange surfaces of the lung. This is the picture showing normal airway and in airway with patient with COPD. In patients with COPD, there will be airway remodeling, fibrosis, smooth muscle contraction, leading to airflow obstruction. As there is airflow obstruction in expiration, there will be alveoli hyperinflation. Risk factors for COPD. Most common risk factor is exposure to tobacco, passive smoking, occupational exposure, ambient air pollution, and genetic abnormalities like alpha-1 antitrypsin enzyme deficiency. And coming to emphysema, it affects the distal structures which are distal to the terminal bronchiole, which includes acinus. Acinus, it is composed of respiratory bronchiole, alveolar ducts, alveolar sacs, and alveoli. These are the subtypes of emphysema: centrilobular emphysema, panacinar, and paraseptal. These are the three types of emphysema. Coming to the centrilobular emphysema, which is proximal to the acinar, there will be destruction of central portion of acinus, which is mainly respiratory bronchiole. It is mainly associated with cigarette smoking. This is the picture showing centrilobular emphysema. Here mainly the respiratory bronchioles are affected. Coming to the panacinar, this is the enlargement or destruction of all parts of acinus. This is most commonly due to alpha-1 antitrypsin deficiency and in smokers. And this is the picture showing terminal bronchiole, respiratory bronchiole, alveolar ducts and alveoli, and septum. In panacinar, mainly there will be enlargement of all acinus, all parts of the acinus. And coming to the paraseptal variety, here it is also known as distal acinar. The alveolar ducts are predominantly affected. This is the picture showing where alveolar ducts are predominantly affected. Coming to the pathophysiology, mainly chronic inflammation plays a central role in COPD. The main trigger factors for COPD are smoke and pollutants, which leads to inflammation, and it leads to chronic inflammation and structural changes, mainly bronchoconstriction, increased secretion of mucus, edema, leading to emphysema, which finally leads to airflow limitation. As in COPD, there will be expiratory flow limitation, air trapping, leading to hyperinflation. Patients mainly present with breathlessness, leading due to reduced exercise capacity, which may lead to poor quality of life. Chronic bronchitis. It is defined as productive cough, and it should meet the following criteria: at least 3 months for 2 consecutive years, without any identifiable cause for excessive sputum production, and the airflow limitation is not fully reversible. Causes include smoking, noxious stimuli like smoking. And patients with chronic bronchitis are known as blue bloaters, where they have mild dyspnea and the cough is predominant symptom with copious and purulent sputum, more frequent infections, and these patients are more prone for cor pulmonale. Emphysema. These patients are also known as pink puffers. Here, patients with emphysema mainly presents with dyspnea, cough after dyspnea, and scanty sputum. There will be less frequent infections, and terminal respiratory failure and cor pulmonale are rare. These are the differences between chronic bronchitis and emphysema, where chronic bronchitis is more of cough predominant, whereas emphysema is more of dyspnea predominant. And in chronic bronchitis, there will be more of sputum production, and in emphysema, there will be less sputum production. And most common causes for chronic bronchitis is infections, and less common cause, and in emphysema, there will be less frequent infections. And the most organisms responsible for infection are Moraxella catarrhalis, Haemophilus influenza, and Streptococcus pneumoniae. Coming to the physical examination, patient may be normal, or maybe in chronic patients they may have hyperinflated chest, which is known as barrel chest, where AP and the transverse diameters are both equal. And patient may have pursed lip breathing due to accessory muscles of respiration. Here the patient will have pursed lip breathing due to prevent the collapse of alveoli. He will use the accessory muscles of respiration to prevent the collapse of alveoli. So we will see the pursed lip breathing, and they may have wheeze or quiet breathing. And if the patient with COPD may develop right heart failure, they may present with peripheral edema, cyanosis, raised JVP, and they may also have cachexia, cough, wheeze, dyspnea, and sputum. This is the normal chest, and this is the barrel-shaped chest, where in normal chest, transverse diameter is more than AP diameter, whereas in barrel chest, AP and diameters and both are equal. Coming to the clinical manifestations, patient with COPD has three primary symptoms, which are cough, sputum production, and dyspnea on exertion. Sometimes dyspnea may be so severe and it interferes with the normal activities. And patients may also have weight loss due to dyspnea, as dyspnea interferes with eating. Coming to the inspection, on inspection, patient may have barrel chest, and he may use accessory muscles of respiration, and he may have prolonged expiration through pursed lips to prevent collapse of alveoli, paradoxical retraction of lower intercostal spaces during inspiration. It is known as Hoover's sign. And tripod position. This is the tripod position, which we commonly seen in our bedside clinics in patients with COPD, where the patients adopt this position, which includes leaning forward with arms outstretched and weight supported on palms or elbows. This is the position. This is the tripod position. Coming to the palpation. On palpation, there will be decreased vocus primitus. On percussion, there will be hyperresonant, and there will be increased cardiac dullness. On auscultation, there will be prolonged expiration, reduced breath zones, and there may be wheeze or crackles. Crackles may be heard if patient has infection. These are the key factors which help in assessing the patients with COPD. First, we should ask when you diagnose a patient with COPD, first we should ask these factors. First thing is exposure to any risk factors like any infection, smoke, or any air pollution, occupational exposures like that. And past medical history. As it is a chronic condition, patients may have previous history of any respiratory problems, asthma, allergy, sinusitis, nasal polyps, and any history of respiratory infections. And may have family history of COPD or other chronic respiratory diseases. As COPD, one of the common causes due to alpha-1 antitrypsin deficiency, we should inquire in the family history about COPD. And coming to the pattern of symptom development, on the basis of symptomology, we can differentiate between whether it is chronic bronchitis variety or chronic emphysema variety. As in chronic bronchitis, there will be more of cough predominant asthma, whereas emphysema, there will be more of dyspnea. On basis of the symptoms, we can differentiate them into chronic bronchitis or emphysema. And we should ask about the history of exacerbations, like how many exacerbations in a year, in a month, and any previous hospitalizations, and any comorbidities, and any medical treatments, previous medical or any current medical treatments he is using. And, and we should assess the impact of disease on the quality of life and social and family support for the patient, and reducing the risk factors, like we should advise the patient to stop smoking and to follow the occupational measures. And pulmonary function tests. These are mainly used to confirm the diagnosis of COPD and to assess the severity and follow the disease progression. Pulmonary function test, which mainly includes spirometry to evaluate the airflow obstruction, and ABG to assess the baseline oxygenation and gases exchange, and chest X-ray and alpha-1 antitrypsin deficiency screening should be performed in all patients who have any family history of COPD or who presented with chronic breathlessness before 45 years of age. And this is the spirometry. Now, spirometry findings include decreased FE1, decreased FVC, and FE1 will be less than 80%, and FE1 by FVC ratio will be less than 70%. In patients with COPD, on post bronchodilator, there will be no change in FE1, whereas in asthma, there will be reversibility. This is the one of the main difference between asthma and COPD, where in COPD, there will be low reversibility. And peak expiratory flow rate will be decreased and Vmax will be decreased. This is the classification based on severity of airflow limitation in COPD. In patients with COPD, there will be the FE1 by FVC ratio will be less than 0.7. There will the severity is based on GOLD guidelines, where it is classified into four categories. In mild variety, the FE1 will be more than 80%. In moderate, it will be between 50 to 80. In severe, it will be FE1 will be in between 30 to 50. Whereas in very severe, FE1 will be less than 30% predicted. This is very important classification. To categorize the patient on the basis of severity of airflow limitation on spirometry after post-bronchodilator. This is the chest X-ray of a patient of chronic bronchitis. In chronic bronchitis, the X-ray may be normal or may have increased vascular markings or increased vascular markings. Whereas in patients with emphysema, there will be overinflated lungs and widening of intercostal spaces and a horizontal pattern of ribs and long thin heart shadow. And there will be decreased lung markings in emphysema. Whereas in chronic bronchitis, the markings will be increased. Whereas in patients with emphysema, the markings will be decreased. The lungs will be overinflated and widening of intercostal spaces, and there will be horizontal pattern of ribs and long thin heart shadow. This is the X-ray showing patients with COPD, where their heart is enlarged and the lungs are hyperinflated, widening of intercostal spaces with flattened diaphragm. Coming to the next investigation, CT. CT mainly used for evaluation of any bullae, emphysematous bullae. Coming to the treatment, these are the objectives of COPD management, which includes, first, our goal is to relieve the symptoms and to prevent the disease progression and reduce the mortality and improve the exercise tolerance and to prevent and treat the complications. Principles of management. For a patient with stable COPD, inhalational treatment is preferred. The group of drugs which we used in asthma and COPD are both same, but the difference is only that what we choose in a patient with COPD first and in patient with asthma. In patients with stable COPD, first we will use LAMA, which are long-acting antimuscarinic agents are the first choice. And the second choice are long-acting beta agonists. And the third choice are inhaled corticosteroids. And in case of exacerbations, we will use short-acting beta agonist and short-acting antimuscarinic agent. There is no role of steroids in patients with stable COPD. These are the short-acting relievers, which are short-acting beta agonists like salbutamol, levosalbutamol, and terbutalol. Short-acting antimuscarinics like ipratropium bromide. And coming to the long-acting relievers and controllers, long-acting beta agonists are salmeterol, formoterol, whereas long-acting antimuscarinics are tiotropium bromide. And inhaled corticosteroids like beclomethasone, budesonide, and fluticasone. Our main aim of treatment is using LAMA as first choice, LABA as second choice, and ICS as third choice. As it is a chronic condition, our main aim is to prevent exacerbations and for airway remodeling. Inhaled therapy. These are the mainstay, which are delivered as aerosols or powders. They directly deliver the medications to the airways so that first pass metabolism in liver is avoided and low doses are necessary to control the exacerbations and systemic side effects are minimized. And coming to the assessment and management, mainly diagnosis is by spirometry, where FE1 by FEC ratio will be less than 0.7, and we will assess the airflow limitation based on GOLD criteria. And next, which is another classification of based on symptoms and exacerbation history, where patients are categorized into 4 groups on the basis of MMRC dyspnea scoring. Patients are graded into four categories and based on exacerbation history. Smoking cessation and pulmonary rehabilitation and influenza and pneumococcal vaccine. These are the main supportive therapy. In patients with group A, where there will be MMRC breathlessness of 0 to 1 and patient is not having any exacerbations. We will treat him with bronchodilators like salbutamol and short-acting antimuscarinic agent like ipratropium bromide for category A. Coming to the category B, where he is having no exacerbations but MMRC breathlessness grade is above 2. We will treat him with long-acting. As a patient is having more of breathlessness, as grade is increasing, we will treat him with long-acting bronchodilators like LAMA, LABA, or both LABA and LAMA. Coming to the long-acting muscarinic agent, tiotropium bromide, long-acting beta agonists like salmeterol and formoterol, or both LABA and LAMA. Coming to the category C, where patient is having more than 2 exacerbations requiring admission and where his breathlessness grade is less than 2. Patient falls in category C. For category C, the patient will be treated with LABA or LAMA and LAMA plus LABA or long-acting antimuscarinic agent with inhaled corticosteroids like budesonide, fluticasone. In third group, we will add steroids. In first A and B, we are using only bronchodilators. In group A, we are using short-acting bronchodilators, whereas in group B, we are using long-acting bronchodilators. In category C, we are adding steroids to prevent the inflammation. Coming to the category D, which includes more than 2 exacerbation history, and his breathlessness grade is also 2. patient will be treated with all the following medications along with roflumast and macrolides to prevent exacerbations, and to mainly to treat the infections macrolides are added, and roflumast is a mast cell stabilizer. Coming to the management of exacerbations, and the most common causes for exacerbations are infections. Infections with Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis, and air pollution, and due to smoking. In 30% of patients, the cause is not known. For exacerbations, patients are mainly treated with antibiotics, systemic steroids, and mechanical ventilation if needed in emergency situation, and oxygen therapy. Only low flow, avoid high flow oxygen therapy. Smoking cessation is most effective intervention in patients with COPD. And say bronchodilators, they will relieve the bronchospasm and will reduce the airway obstruction and will increase the oxygen distribution throughout the lungs and improve the alveolar ventilation. This is the mechanism of action of bronchodilators. These play a central role in management of COPD, and they are delivered through metered-dose inhaler by nebulization or via oral route in pill or liquid form. Metered-dose inhaler is a pressurized device containing an aerolized powder of medication. This is the metered-dose inhaler. This is the mouthpiece. This is the inhaler. This is the mouthpiece, mouth end, which should be kept in the mouth. After taking deep inspiration, we should press this releaser where drug will be delivered directly through the air to the airways. After that, patient should take deep inspiration. After finishing it, he should wash his mouth to prevent infections, fungal infections. This is the metered-dose inhaler. Corticosteroids, where inhaled and systemic may also be used, but systemic are mostly used in asthma but not in COPD. These medications will slow the decline in lung functions and may improve the symptoms. Other medications which play a main role in patients with COPD include vaccines. Main vaccines are influenza vaccines and pneumococcal vaccine, as the most common causes for exacerbations are Haemophilus influenza and Streptococcus pneumonia. We should treat the patient with these vaccines to prevent the exacerbations. They should be given, influenza vaccine should be given every year, whereas pneumococcal vaccine should be given every 5 to 7 years. Coming to the management of exacerbation, the most common clinical features for exacerbation include increasing dyspnea, increasing sputum production and purulent sputum, increased respiratory failure, change in mental status, or worsening of blood gas abnormalities. These are the clinical features for exacerbation. And the primary causes, as we already discussed, infection and air pollution and smoking. Oxygen therapy. It is the main therapy administered as long-term continuous therapy during exercise to prevent acute dyspnea. This long-term oxygen therapy will improve the patient's quality of life and survival. In end stages, mainly oxygen therapy is given to prevent the complications like pulmonary hypertension and copd. As due to chronic hypoxia, it will lead to constriction of pulmonary vasculature. We will supplement the patient with continuous low flow oxygen, minimum of 15 hours in a day, to prevent the complications like pulmonary hypertension and copd. In areas where as patient, we can't admit a patient in hospital and give the 24 oxygen. We will use oxygen generators on home based. This is the oxygen therapy which should be given more than 15 hours per day, which improves survival, exercise capacity, sleep, and cognitive performance in patients with respiratory failure. And our goal is to maintain the saturation more than 90% and partial pressure of oxygen more than 60 mm of Hg. Coming to the surgical management include where in a for some patients there will be emphysematous bullae. The surgical management include bullectomy, where bullae are enlarged air spaces that which do not contribute to the ventilation but occupy space in thorax. These areas may be surgically excised. And next surgery is lung volume reduction surgery. It involves removal of a portion of diseased lung parenchyma. This allows the functional tissue to expand, and lung transplantation. Finally, coming to the complications, the complications include main complication include respiratory failure, which is the most life-threatening complication of COPD. And next complications include pneumonia and respiratory infection, and right side and heart failure. As chronic hypoxia leads to pulmonary vasculation, it leads to right heart failure. In turn, leads to increased pressure in right-sided vasculature, leading to right heart failure and pulmonary hypertension. The right side heart failure is known as cor pulmonale, and pulmonary hypertension, pneumothorax, skeletal muscle dysfunction, depression, and anxiety disorders. And the difference between asthma versus COPD. The main differentiating features between asthma and COPD is in asthma there won't be the cough is not always productive, whereas in COPD the cough is mostly productive cough. Whereas in asthma, it is an by the definition, it is an reversible airflow obstruction. Whereas in COPD, it is not it is not completely reversible. And for asthma, there will be associated history of any allergies. Whereas there will be in COPD, there will be history of smoking. Coming to the symptoms, in patients with asthma, cough will be more at night and early mornings. Whereas in COPD, cough will be present throughout the day. In asthma, there will be a family history of any atopic history or asthma, whereas there will be no family history. There will be asthma mainly a disease of childhood, whereas COPD mostly in elderly. COPD mostly in older adults, whereas asthma can affect any age group, mostly children. In COPD, there will be non-allergic response, whereas there will be allergic and non-allergic in the asthma. Coming to COPD, there will be genetic factors like alpha-1 antitrypsin deficiency. Coming to the pathology, there will be inflammation and damage to the airways in lung and lung tissue. Whereas in COPD, the lung function cannot be completely reversed even with treatment. Whereas in asthma, lung function is reversible with treatment. In COPD, there will be little or no improvement with short-acting beta-2 agonists. Whereas in COPD, the symptoms will get worse over time. Whereas in asthma, there will be intermittent or persistent symptoms and acute episodes often occur. Thank you.